Hello, my name is Faaria, and I'm a medical student at the University of British Columbia. I'm here today to present some mixed methods findings on the stigma trajectories, disclosure, access to care, and peer-based supports among African, Caribbean, and Black immigrant women living with HIV in Canada. Normally, I would present this project with one of our co-authors, but given current COVID restrictions, I'm going to be presenting on behalf of our amazing team at the Center for Gender and Sexual Health Equity. Before I begin, I would like to acknowledge that our work takes place on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. It is important to recognize that our intentions on this land are to understand the ongoing effects of colonization, to challenge our biases about Black, Indigenous, and people of color, and to commit to incorporating this work into our practice as researchers and/or physicians. Studies have shown that ACB immigrant women experience a disproportionate burden of HIV relative to people born in Canada. Specifically, the Public Health Agency of Canada has indicated that in 2011, people from countries where HIV is endemic made up only 2.5% of the Canadian population, but in 2016 represent 13.6% of new diagnoses. Of those individuals, women from primarily sub-Saharan Africa and the Caribbean made up 46.3% of reported HIV cases. Despite this research, there is scarce empirical evidence about the unique individual, social, and structural challenges that ACB women encounter throughout their resettlement journey, from pre to post-migration, that shapes access to both HIV treatment and support. Therefore, the objective of this study was to understand how stigma and immigration trajectories shape access to HIV care and peer supports among ACB immigrant women living with HIV in Canada. Our research is nested in the Shauna study, which is a longitudinal community-based research project with over 350 cis and trans women living with HIV in Metro Vancouver. The project focuses on the social, political, legal, gender, and geographic gaps in women's sexual health and HIV care, and is a collaboration with a diverse team of researchers, community, legal, and policy experts, and women living with HIV. As part of the cohort, participants complete a baseline and follow-up interview every 6 months and receive voluntary CD4 measurements and serology for STIs and hepatitis C. There is also a qualitative and arts-based research program which complements and enhances the quantitative findings. Our mixed method study drew from Shauna participants who self-identified as ACB and currently live with HIV. In total, we had 20 cohort participants and 9 in-depth interviews. The quantitative portion of our study consisted of bivariate and multivariable logistic regression using GEE modeled associations between having an ACB background and outcomes which included stigma, HIV disclosure, and social support. Furthermore, the qualitative interviews explore the interplay between migration trajectories, stigma, racialization, and HIV, and were transcribed using a social and structural determinants of health framework. Based on our quantitative findings, the median age for our participants was 43 years old, with 35% identifying as a sexual minority and 10% as a gender minority. In the bivariate analysis, we found that women with an ACB background were more likely to firstly be outed as HIV positive without consent within the last 6 months, secondly, be verbally and physically abused due to their HIV status in the last 6 months, thirdly, to not miss ART treatment within the last 4 weeks, and fourthly, be less satisfied with the social support they received from family and friends. Based on our multivariable analysis, after adjusting for confounders, we found that participants were significantly more likely to be outed as living with HIV without consent. Many of our quantitative findings were also reflected in the qualitative narratives shared by our participants. 3 key components were identified, each centered on the relationship between HIV disclosure and stigma that shaped women's experience living with HIV, accessing care, and receiving support in Canada. These components were categorized as factors that contributed to the migration to Canada, navigating the Canadian healthcare system, and lastly, social support and resilience. Our first theme, migration to Canada, was subdivided into 2 sections, the first being war and experiences of violence. Participants stressed the detrimental effects of war, conflict, political violence, and sexual violence that stemmed from the global economic and financial imbalances between developed and developing countries. Consequently, participants and their families were forced to immigrate, leaving behind very unsafe living conditions. Participant 1 described her reasoning for immigrating. She said, "I came to Canada just because of the political situation, and my husband was arrested. I was also kidnapped. It was around election time I was kidnapped. because they wanted to, they were raping girls all the time. Participant 2 described a similar scenario. She said, and the war came, and there I was. We suffer a lot, struggling and asking United Nations to help us, to resettle us, and our day throughout the struggle was too hard. The second theme within migration to Canada consisted of experiences of HIV stigma. Participant narratives highlighted the very serious and negative repercussions of HIV stigma within their place of origin. For many, it was impossible to continue living there without fearing for their lives if their HIV status was disclosed. Furthermore, and as reflected in our quantitative results, this fear and distress continued upon migration into Canada, as many continued to experience verbal and physical abuse due to their HIV status being disclosed without consent. Participant 5 shared, "Oh, if I stayed in my country of origin, I think I could not be there now. I could be dead because, as I told you, in the country of origin, people frustrate people so much when they hear that you are HIV." Participant 7 described a similar sentiment. She said, "It's just where I come from. When people find out you're positive, they kind of treat you like a reject and you're dead. You don't talk to people about it because you know how they're going to react. So the best way is just to keep it inside." Upon arrival into Canada, many participants experienced racism and othering that worsened the fear and anxiety they already felt living with HIV. Although many spoke positively about the presence of HIV-specific and women-centered HIV care, in the context of having experienced racism, accessibility was limited by fear of inadvertent disclosure of HIV status to members of the community. When asked to describe accessing HIV-specific care, participant 3 responded, "Some women, they're in hiding. They don't want to be seen when they go to the clinic, because not all Black people like to be. Once they meet you at the HIV-specific service, you know the whole community is going to know." Participant 2 also described her fear about her HIV status being inadvertently disclosed to community members. She said, "You know we are Black. She will tell the other people that came away from other countries. And when she tells them about my HIV status, it starts going back to the country that I came from. It will not look good." As established in our bivariate analysis, many women were unsatisfied with the level and quality of social support they received. Participant narratives stress the importance of enhancing peer-led social supports in order to share stories and create a supportive environment. Specifically, the first interaction was vital in helping create a safe space where the women felt more comfortable sharing their own experiences living with HIV. Participant 2 shared her experience interacting with a peer-led support group for the first time. She said, "The first day I was sharing my story, it was a retreat, and then that's when I just felt comfortable sharing my story. And also, it was a safe place for all the women, so that was a good change." The significance and need for social support groups was further emphasized given recent cuts in government and program funding, as highlighted by participant 3, because we don't have funding, but once in a while we used to come out like in the sunny day, and we go to the park and entertain the kids, cook, eat together, which was very meaningful, but now we don't have anything like that. Our findings suggest that the immigration trajectories of ACB women living with HIV compound HIV stigma and discrimination and are critically related to accessing HIV care and supports in Canada. In order to improve access to HIV care for ACB women living with HIV, it is vital that we first understand and respond to the trauma of war, conflict, and political violence that ACB women experience, and understand how these factors shape the level of trauma and fear that women carry throughout their lives. Second, understand the stigma and discrimination that ACB women living with HIV encounter both pre- and post-migration, and incorporate migration trajectories into HIV programs. Our focus on the continuum of women's lives highlighted the interconnected nature of stigma and discrimination experienced within the place of origin and within Canada. It is vital that we continue to address this trajectory as we seek to improve HIV care and services. Third, increase efforts to ensure privacy and confidentiality in order to build trust in the context of clinical encounters. It is important that HIV services foster a sense of safety, collaboration, transparency, and trust, all the while reassuring participants of their right to privacy. And lastly, we need to work closely with the ACB community to develop culturally sensitive and trauma-informed HIV services rooted in peer-based approaches. A peer-based trauma-informed model of care can present opportunities for women to disclose their HIV status, to form relationship with others in similar circumstances, and can also be crucial in helping participants navigate living with HIV and act as a bridge towards seeking care and treatment. We thank all those who contributed their time and expertise to this project, particularly participants, peer research associates, Shauna Community Advisory Board members, partner agencies, and the current Shauna team. Thank you.